You talk specifically about Dr. Hughes's use of I think you called it the PCL-5.
Yes. So the PCL-5 is the post-traumatic stress disorder checklist. This is different, not to be confused with the CAPS-5, which I've talked about previously as being the gold standard. The PCL-5 was developed by the National Center of PTSD. It's intended for treatment. So if I were, for instance, working with a service member who I know had been in combat, I would probably give this as a standard with my intake. Before we do the diagnostic interview, it kind of gives me a read on how somebody who's there for treatment, who we assume can be taken at their word, because if they give us correct information, they're going to get an appropriate treatment. And if they give us incorrect, they might not get the treatment they need. So I would give this checklist to them, and then if they recognize some of those symptoms of PTSD, they could check it off. And that would probably indicate to me that I need to then do the next step. If they're checking off more items than not, I would probably decide to administer the clinician-administered PTSD scale, that gold standard interview, to find out more about a diagnosis.
The last was the CAPS-5?
Yes, the CAPS-5.
What about, well, you talked about forensic use. What do you mean by that?
So when I'm talking about forensic evaluation, that's an evaluation that isn't done for therapy or treatment. It's specifically to assist the fact finder, to assist the judge or the jury in the court by providing information about the psychological status about an individual. And that's an important delineation too. We are not psychologists. I wish we were mind readers. I wish we had a crystal ball and could find out whether intimate partner violence occurred and look back in the past. But it's nothing like that. Really, it's a lot less interesting. We look at data. We have to control for those response biases. And then we also are looking at functioning, which is really the bottom line of the assessment. Did the person have a change in functioning from before the alleged trauma, or in this case, the alleged IPV, to after? Is there a decline in the way they're going about their lives?
And Your Honor, may we approach?
All right. Is likely to endorse these items even though they're not real PTSD symptoms. With PTSD, so sometimes people score higher on this even when they do have PTSD. She scored so high that that is effectively ruled out as a possibility.
Okay. What about Dr. Hughes's administration and use of the CAPS-5?
Okay, yes, heard. With PTSD, back in 2019 when she began testing her, it wasn't until 2 years later, more than 2 years later, 10 days after I administered the CAPS-5 with Ms. Hurd, that Dr. Hughes held an impromptu evaluation session remotely with Ms. Hurd and administered the CAPS-5. She had previously diagnosed PTSD without using what we consider to be the gold standard PTSD diagnostic interview. And again, when we're doing a forensic evaluation, it is an important responsibility, and part of our ethics and professional standards are that we document everything to allow for transparency and full judicial scrutiny. And Dr. Hughes administered it incorrectly. She left huge sections, very relevant sections, blank. There's no way to understand why she scored it as high as she did based on the information that's provided. You're essentially supposed to notate the examinee's responses as verbatim as possible to explain your reasoning and implying their scoring procedure. It's a standardized test, and if you don't follow those standard procedures, it's completely invalid. Not only that, but it looks as though Dr. Hughes further invalidated it by trying to show that she had assessed for the childhood trauma impact, and she had said that she went back and asked the childhood question, but you can't do that. If you're assessing for 2 separate periods of one's life to find out the relatedness to PTSD, you do 2 separate CAPS interviews, period. You don't.
All right. You also mentioned with respect to the PAI, or the Personality Assessment Inventory, that Dr. Hughes failed to mention some elements. What did she fail to mention?
Oh, okay. So on the personality assessment inventory, so first she failed to mention that were clear indications of response distortion. She also failed to mention that Ms. Hurd scored in her score profile against their main scores. She did elevate a score for the borderline personality disorder sort of section, but that in and of itself would not indicate a diagnosis. However, the configuration of her scores overall is consistent with that, and in fact, it's one of the diagnostic suggestions given by the test itself. And then also, there's a configuration around Ms. Hurd's trauma responses on that particular test, which demonstrates that it is more likely that those symptoms were reported in relation to something in the distant childhood. It's more consistent with childhood chronic abuse than present circumstances or recent circumstances. I would say the main issue was that she said that Ms. Hurd obtained a normal profile on my MMPI-2.
All right. How do you disagree with Dr. Hughes relative to the profile?
Okay, so the profile was not normal. So Ms. Hurd already had subtle elevations just by the test by itself as it came out. There were subtle elevations, but they were elevations that if the validity scales hadn't been as elevated as they were, you might have said this person has some traits, but this isn't necessarily at the level of a true pathology. However, Ms. Hurd elevated a scale that essentially is a defensiveness scale on this test. And when you're giving this test, you always are mindful of different norms or groups who may have similar profiles. And there are certain groups of litigants who tend to elevate this scale as well. So I had that in mind. However, Ms. Hurd elevated this so much that it was far beyond the mean for the litigants that are known to have the highest levels of this scale, this defensiveness scale. And when this scale is elevated to the level that it is, you automatically understand that it is very likely that those clinical scales, I keep doing this because I'm seeing it in my head, it looks like sort of an ECT. It's sort of these peaks you see on a graph. And when you see these peaks, and you have this huge peak over here for the defensiveness scale, what you know is that these peaks are artificially, they've been lowered or suppressed based on the respondent being so defensive. They still detected what's likely there for her, but it's not as high as it should be. So you make an adjustment. And the recommendation is that anything at 60 or above, we call it a T-score of 60 or above, is considered significant. Ms. Hurd's were already over 60. Some were quite higher than that. And then you see a very clear profile. And that was how I got that. I mentioned a 3-6 code type. Now, the test does its own correction also for some of the scores, but not the ones that are her main code type. With the test correction, she had a 1-3-6 code type, which is very similar. And the traits with a 3-6 code type tend to be marked by a lot of externalization of blame, a lot of denial about one's own personal faults, intentional or not intentional, but just extreme denial, hostility that is strongly controlled and suppressed. The person may not even realize how hostile they are, but family members, those closest to them, are very likely to report that they lose their temper, and when they lose their temper, it explodes. We have sort of what we call a cookbook for these code types, which will provide you with all the information that's been researched to be associated with them. And our cookbook actually states that that 3-6 profile specifically tends to be associated with cruel and ruthless behavior, particularly to those who they perceive as less powerful than them and subordinates. Analysis of the scores, I do this for every test, and I also did it when I was reviewing Dr. Hughes's scores. So what you haven't seen that's in Discovery is that I created a 25-page outline just of her scores with, and it's sort of a table. So I'll put the score, I'll do it in sections so that I can understand different groupings, different research studies, and I start with looking at all the validity scales. So I put in the score, I put, and I'll even color the table to show me if it's kind of in the high zone, moderate zone, or low. And then if it's low, is it a significant low score, or is it just low so it doesn't mean anything? And then in the right side, I put all the research data that I found on this particular scale score. And so I start with the validity scales, the way the person approached the test. Then I go down to essentially, we call these the first factors. So their overall sense of well-being and how well they cope. On this, actually, Ms. Hurd's, she endorsed scores or endorsed items that were the opposite of PTSD. So really saying that she feels free of distress and that she views herself very well. So then I go down to control, self-control, loss of control, coping abilities, and I put in the scores that are associated with that in the research and the test development. Then I go down to clinical and personality pathology, and I look at all the scores that are significant there, first with the top level main scores, then with all of the different sub-scores, again, citing the research, the meaning, the level of elevation, and what that means. And then I do comparison with different research groups. So for Ms. Hurd, I did a section that looked at all sorts of different scores that have been implicated with a PTSD presentation to see if any of those were consistent. I can't remember how many there were. I think I put 13 on there, but I could be wrong. But I believe that there was only one that could even be, in some research, is sometimes associated with it, but it was general anxiety, which turned out to be more trait specific. I looked at the scores that are typical of women with IPV. Hers were not consistent at all with those. I looked at the scores that were consistent with people who are frequently in litigation. Hers actually were very highly correlated with those. That tends to be also consistent with a 3-6 code type, and the reason for that is believed to be that they tend to perceive themselves often as victims who need to avenge wrongs.
Were there...
So that 98th percentile score just represents that among 98% of people who take that test would not have endorsed. She scored more of those unusual items that are not consistent with PTSD than 98% of people who have ever taken that test. Well, feigning is essentially exaggerating symptoms of a disorder.
I think the third thing you indicated you were going to talk about was self-reports and personal opinion as facts. What are you talking about there?
So in any science and in psychology specifically, it's really important that we use precise language and we say what we mean, and we do not present opinions as facts, because when you are in the role of an expert witness or an expert in any setting, essentially a layperson may not be able to detect the difference between something that is a personal opinion that you're giving versus something that is substantiated by research data, test data, reliable test methods. So our ethics talk about, especially the specialty guidelines of forensic psychology, the responsibility we have to distinguish between data, then inferences we're making from that data, what the data can mean, sort of like those tables I do. I put the data, the inferences based on the research, and then what my ultimate opinion is, integrating all of that data. And it's very important that we clarify that to the fact finder, to the judge, the jury. That's our responsibility, that we do not cloak.
What do you mean by self-report?
The self-report is essentially what the examinee tells you during the interview.
Okay. When did Dr. Hughes do this most?
She did this most when describing instances of alleged IPV, and there's also an issue there because one of our ethics also discusses the importance of relevance and withholding, essentially constraining our testimony to the data and not including private information, personal information that unnecessarily compromises the dignity of any of the litigants. She provided a lot of what was Ms. Hurd's report to her, the allegations of abuse, when describing Mr. Depp, who she had not examined, when describing Mr. Depp's behavior, his motivations. I believe she used the word obsessive jealousy quite a few times, talked about Ms. Heard being in a highly dangerous situation. These are simply things that we cannot detect based on testing and a psychological evaluation. We have to evaluate the person, we have to get consent, and we can only describe an individual, not whether or not IPV has occurred. And we certainly shouldn't go into explicit details about sexual encounters or other things that are highly prejudicial, shocking, and hard to forget. The results of my multi-method comprehensive evaluation based on carefully selected, researched, relevant test instruments, based on comparing those instruments to Ms. Heard's self-report, observing Ms. Heard's behavior over 12 direct hours of assessment, reviewing copious notes from prior therapists who indicated symptoms in their notes, reviewing the notes of Nurse Filati, previously Nurse Borum, who spent, I believe at one point, almost 2 months with Ms. Heard daily, reviewing the notes of her treating providers, all of the legal documents and discovery. There was no evidence of PTSD.